to make the patient functional performance equals to the uninjured control subject. We have evidence for this muscle. This using this muscle dynamometry, we can quantitatively assess and objectively examine through dynamometer. The second one is single leg hop test, which assess the dynamic stability of the joint of athlete and its sports related knee function side to side symmetry. It is 90% or greater as criteria, and limb symmetry indexes and single leg hop for distance, triple hop for distance, and crossover hop for distance differ between control and athletes who had ACL reconstruction. Symmetry of the triple hop for distance was most strongly correlated to self-reported function of the four boxes. We usually do this hop test to assess the stability of the joint in a technique and functional position. The other thing is tuck jump. Tuck jump is assess the trunk stability and the lower extremity asymmetry and quality of mechanics after the ACL reconstruction. It also needs to be 80 points before returning the patient to normal sports. And so, for this, I would suggest that the feedback provided in tuck jump technique reduces knee abduction motion during the drop vertical jump. That is while landing, when the knee is going in valgus position, it will be cause re-injury. So we need to assess this through tuck jump. And drop vertical jump is jumping from a 1.5 feet of height of stable, and it assesses lateral and frontal knee mechanics, and it needs to be 60% normalized knee separation distance. And evidence for this is sagittal and frontal knee motion during drop vertical jump is a part of clinical algorithm that accurately predicts high external mega pressure. High pressure internal load is the main cause of re-injury which occurs while landing. Patient reported outcomes which we do for athletes is what they think. When we get a patient after ACL reconstruction, we have tendency of phobia, a term which has been introduced very recently. The fear of patient in doing movement of reconstructed knee. So this causes a lack of confidence in them, and there is lack of readiness to return to play. So these are the proposed method of assessment after ACL reconstruction, which we do. This is dynamometer attached to the patient ankle, and he is doing quadriceps isometric maximum. A single leg hop test in the first picture. Single leg hop test for distance, hop test for time, and the other is tuck jump. This is the drop vertical jump, starting from the single leg and landing on double leg. And after landing, the patient is asked to jump for again. First, drop vertical jump. This is the patient report of 2000 IPDC subjective knee evaluation form. It's a subjective assessment of the patient readiness and patient subjective feeling about the reconstructed knee and his readiness to return to play. These includes sports activities also. So a scoring for normal individual or housewife reconstructed knee is not equally can be done with the athletes. Athletes assessment must include the sports activities assessment also, and the other cutting, pivoting, and high demanding, sports demanding assessment. The importance of neuromuscular training after ACL reconstruction. The pooled estimate found a risk reduction of 52% for female athletes and 85% of male athletes with implementation of neuromuscular training. This decreases the risk to this. The neuromuscular training, if we implement in ACL reconstruction, it decreases the risk reduction is decreased to 52% in female athletes and 85% for male athletes. Neuromuscular training may allow ACL RA athletes to safely and effectively return to sports, and ideally this training program would be implemented at the end stage of rehabilitation or just prior to returning athletes back to sports. Even after medical clearance, they need this training. So it is the last stage of training. Neuromuscular training is considered the last stage of training, which prepares the athletes for a sports specific demand. Neuromuscular training program produces significant biomechanical correction of altered knee sagittal and frontal plane angle and movements in a cohort of ACLR athletes, since these measures have been implicated in a greater risk of ACL. So all the exercises which we will introduce in the next slide includes 4 phases of difficulty, 4 phases of training. The first phase starts with a usually 2-leg, well-supported, unidirectional single-leg task, which the difficulty level improves to double to single-leg transition and decreasing the stability of support surface, narrowing the base of support. In the third phase of the training, we introduce second perturbation to the athlete's neuromuscular system using ARX plus ball or BOSU ball. And in the fourth phase, that is return to sports, multi-directional tasks that demand explosive movement and quick repetition, unstable surfaces and destabilizing perturbation needs to be introduced in the fourth phase, and it should be sequentially progress to avoid injuries. So, what exercises which have been introduced as neuromuscular training is single leg anterior progression, single leg lateral progression, lunge progression, tuck jump progression, lateral jumping progression, lateral trunk progression, prone trunk stability, and kneeling trunk stability, posterior chain progression, single leg deadlift progression or deadlift progression or lunge jump progression. Few pictures for that. Single leg anterior progression. These are different phases in which we focus on increasing deep flexion of the knees in sagittal plane and avoiding frontal plane aberrations or motion. This is single leg lateral progression using ARX mat and BOSU ball, and then we introduce in third phase a ball to catch, then lunge progression. This is tuck jump progression with bilateral legs with different difficulty level, lateral jump progression, lateral trunk progression. Trunk progression is also required because knee stability or proneness of ACL injuries can be added with the trunk instability. So we need to strengthen hip musculature also and trunk muscles also. These are few exercises which we usually do at our center in ACL injury patients for adding to their trunk stability. Hip muscular strengthening, hip muscle strengthening and trunk stability training is important in avoiding aberration at knee. These are prone trunk stability exercise, kneeling trunk stability. These are the late phase of rehabilitation, so it could be safely done and difficulty level increase phase wise. This is Romanian deadlift progression. This activates the hamstring and quadricep co-contraction very effectively. This is the lunge jump progression, and these are few differences for that. Thank you, sir.
So maybe I'll start with ACL post surgery. The rehabilitation basically you can categorize in three parts. One is early phase,